All right, so a very good evening, everyone. I welcome you all to this particular YouTube session. So, in this session, I will be discussing some of the clinical based questions in the neurology. And these particular questions, they are very, very important questions for your upcoming FMGE exam. Yes, Shadi Shuda, hello. So, as we are very much aware that in the FMGE exams, like very frequently or very commonly, the clinical based questions are being concentrated much. So that was the story on the August 31st. So in order to see that you should not face any difficulty in the upcoming FMGE exam, so I have come up with the discussion on this particular clinical based questions. Okay, right. Now let us start with the first question directly. And I am myself Dr. Rajesh Gubba. I am the general medicine educator on Unacademy platform. Right now, with this, let me start the session. So the first question is that we have a 38-year-old woman having relapsing remitting multiple sclerosis. Right, so a 38-year-old woman has relapsing remitting multiple sclerosis. She has experienced 2 attacks of the disease previously that have left her with the residual lower extremity weakness. Right, that have left her with residual lower extremity weakness. She was initially treated with glucocorticoids and some improvement was there in her symptoms. However, she is currently only able to walk with a rolling walker about 100 meters. A prior antibody testing shows she is positive for reactivity to the JC virus. This is very important. You are planning to start a disease modifying therapy. Which of the following is least appropriate for this individual? Dimethyl fumarate, interferon beta 1A, fingolimod, natalizumab, teriflunomide. Which of the following is least appropriate for this individual? Yes, Shadi Shuda has answered fingolimod, right? So, but fingolimod is not the answer. The answer is natalizumab. Right? The answer is natalizumab. So, in those individuals where the JC virus is positive, right? In those individuals where the JC virus is positive, remember natalizumab should not be given. Right? Natalizumab should not be given. So the answer is the natalizumab. Now, in case of acute attacks of multiple sclerosis, right? In acute attacks of multiple sclerosis, what is the treatment we give? We give methylprednisolone. Right? We give methylprednisolone in the acute attacks of multiple sclerosis. Now, after the acute attacks, like we give disease modifying agents, right? Disease modifying drugs are being given, and we have nearly around 10 disease modifying agents for the treatment of multiple sclerosis that have been approved. Now, what are those agents? These are all the agents. Number 1, interferon beta 1A, interferon beta 1B. Then we have the glatiramar acetate, natalizumab. The entire discussion on this question is about mainly natalizumab. Then we have fingolimod, dimethyl fumarate, teriflunomide, metoxantrone, and then alemtuzumab. So these are the disease modifying drugs which are approved for the treatment of multiple sclerosis, right? Which are approved for the treatment of multiple sclerosis. Now what is the patient's clinical condition? Right? What is the patient's clinical condition? This patient already had the previous attacks, right? If you see here, she was initially treated with glucocorticoids with some improvement, and she had 2 attacks previously. right? Priorly also she had 2 attacks. So now what we need to consider, given this poor functional status, her disease should be treated as the moderate disease, right? Her disease should be treated as moderate disease. Now for moderate disease, what are the preferred agents? Dimethyl fumarate, fingolimod, teriflunomide, and then natalizumab. These are the drugs, and also interferons, right? And also interferons, okay? But these interferons usually we give in milder disease of multiple sclerosis, whereas dimethyl fumarate, fingolimod, then teriflunomide, and as well as natalizumab, these are given for moderate disease, right? These are given for moderate disease. All right. Now the point is, in this clinical scenario, natalizumab is not recommended. Now the question is why? Why natalizumab is not recommended in this patient? Why? Because in this patient, he is having the presence of antibody to JC virus. That is the reason why natalizumab is not indicated in this patient, right? Now what is this JC virus associated with? Very important point is, this JC virus, it is associated with the development of progressive multifocal leukoencephalopathy, right? This JC virus is associated with the development of progressive multifocal leukoencephalopathy. So that's a very, very important point related to your JC virus. Now, what is the relation between natalizumab and as well as the JC virus? Right? What is the relation between natalizumab as the JC virus? The relation is that this life-threatening condition has occurred in 0.3% of all patients with natalizumab, and this life-threatening condition has occurred in 0.6% of patients who are positive for JC virus antibody. That means with natalizumab, 0.3% of patients, they develop progressive multifocal leukoencephalopathy, right? And with JC virus antibody, 0.6% they develop progressive multifocal leukoencephalopathy. That means in this clinical scenario, right? In this clinical scenario, already the patient is having JC virus antibody positive, and that means the chance of development of progressive multifocal leukoencephalopathy is 0.6%. Now, upon that, if you give natalizumab, natalizumab will increase 0.3% chance of development of your progressive multifocal leukoencephalopathy. That is the reason why natalizumab should not be given in this clinical scenario, right? Yes, Shadishuda, we don't know what level of the questions will be asked in your upcoming exams, right? But I'm preparing you for all the types of the questions that can be asked in your exam, right? They definitely may not ask, they definitely may ask, right? Because the FMG exam is going to be completely unpredictable, right? We have to be prepared for whatever the level of the question is, right? Whatever the level of the exam is, okay? Now, the next important thing is, yes. Now, the next important question is, they will ask you very commonly the clinical patterns of the multiple sclerosis. Now, we have 4 patterns of the multiple sclerosis. One is RRMS, that is relapsing remitting multiple sclerosis. Then we have primary progressive multiple sclerosis. Then progressive relapsing multiple sclerosis. Then secondary progressive multiple sclerosis. Out of all these, right, out of all these, which is most common? RRMS is most common, right? Out of all these, which is most common? RRMS is the most common form of the relapsing remitting multiple sclerosis. Now let me show you all the forms. Now this is your RRMS, this one. Now what will be the picture in case of RRMS? In RRMS, you will have a relapse, and then you will have a remission. So you will have a relapse and you have a remission. You have a relapse and you have a remission. Okay. So whenever there is remission, right, whenever there is remission, the individual will be completely off the manifestations. The individual will have no manifestations related to your multiple sclerosis. So this is what is called as relapsing remitting multiple sclerosis, and this is present in almost 85% of cases of multiple sclerosis. Okay, then PPMS, right, primary progressive multiple sclerosis. In case of primary progressive multiple sclerosis, there will be no acute attacks. This is your PPMS, right? In this, there are no acute attacks, right? In this, there will be no acute attacks, but there will be gradual worsening over time, right? But there will be gradual worsening over the time. Okay, so that is what is the story of your PPMS, primary progressive multiple sclerosis. They will not have any acute attacks. Then the other two forms are SPMS, secondary progressive multiple sclerosis. Now what is SPMS? Initially they will have RRMS, right? Initially they will have RRMS, then followed by that there will be progressive multiple sclerosis, right? Followed by that there is progressive multiple sclerosis. That is what is called as secondary progressive multiple sclerosis. That is what is called as secondary progressive multiple sclerosis. Okay, that is your SPMS. Then we have PRMS. What is PRMS? Progressive relapsing multiple sclerosis, right? What is PRMS? Progressive relapsing multiple sclerosis. This will start as primary progressive, right? This will start as primary progressive, but has subsequent acute attacks that will be there. And this progressive relapsing multiple sclerosis, this is the one which has worst prognosis, right? This is the one which has the worst prognosis, right? Now they will be definitely asked in your exam. Yes, boom Shankar, right? We have the RRMS, relapsing remitting multiple sclerosis, PPMS, primary progressive multiple sclerosis, SPMS, secondary progressive multiple sclerosis, PRMS, progressive relapsing multiple sclerosis, right? So these are all the various forms of the multiple sclerosis. Okay, out of all these, which is the most common form? RRMS is the most common form. And which is the one which having worst prognosis? That is PRMS, that is progressive relapsing multiple sclerosis. This is the one which has the worst prognosis, right? Worst prognosis. Okay, right. Now you see the next question. Yes, you are evaluating a 42-year-old woman for complaints of muscle weakness and demic fusion. Very funny question asked by demic fusion. Yes, multiple sclerosis, let me tell you, it is a demyelinating disorder, right? Multiple sclerosis, it is a demyelinating disorder. Yes, demic fusion, are you appearing for this FMGE exam, or which year of MBBS you are? It is a demyelinating disease of the central nervous system. That is what is your multiple sclerosis, right? Okay. No, sometimes we will have students who will be asking questions from the basics, but it's okay. After 2 years, sir. That means you are second year now. Achha, after 2 years you will appear. Achha, now you are asking me to imagine like which year you are now. Very good. Okay, so you are evaluating 42-year-old women for complaints of muscle weakness and tingling in her lower extremities. You should suspect, or you suspect, the peripheral neuropathy. No, it's okay, demic fusion, no problem, right? But it is happy that you are showing interest on the general medicine now itself is really appreciable. Okay, so all of the following questions are important for the history and physical examination of the patient, except Are there any important comorbid conditions? Is there any evidence of upper motor neuron involvement? What does electromyography and nerve conduction studies demonstrate? What is the distribution of the weakness? Which systems are involved? Is it motor, sensory, autonomic, or combination? All of the questions that will be asked related to your peripheral neuropathy except no. So what is that we don't ask? What is not required in the history and physical examination is your electromyography is not required in peripheral neuropathy. Right? Electromyography is not required. So electromyography is related to your muscle pathology, right? We check the muscle action potential by your electromyography. Okay. Now conduction studies, okay, that is accepted. But electromyography, they are not required for the nerve conduction studies. They are not required for the nerve conduction studies. So now there is a criteria. There is a criteria or there is a approach. There are totally 7 key questions that you should ask in a case of peripheral neuropathy. First, what systems are involved? Is it motor system? Is it sensory? Is it sensory motor? Or is it autonomic? Then, what is the distribution of the weakness? Is it proximal weakness? Is it distal weakness? What is that? So, what is the distribution of the weakness? Next, what is the nature of the sensory involvement? Right? Is it temperature loss? Is it loss of touch? Is it loss of vibration? Is it loss of pressure? So, nature of the sensory involvement. Next, you should also ask, is there any evidence of upper motor neuron involvement? How is the evolution? Is it acute, subacute, chronic? Now, is there any evidence of hereditary neuropathy? Can anyone tell me what is the example of the hereditary neuropathy? Any one of you, please? What is the most common type of sensory motor hereditary neuropathy? What is the most common cause of hereditary sensory motor neuropathy? Most common. Huntington's. Okay. Any other? Right, that is your Charcot-Marie-Tooth syndrome. Charcot-Marie-Tooth syndrome, that is the most common cause of hereditary sensory motor neuropathy, right? Next, and the other question that you should ask in a case of a peripheral neuropathy is, are there any associated medical conditions? Are there any associated medical conditions? So that is what you have to ask. 7 key questions that you have to ask in a patient with the peripheral neuropathy, right? So now going back to the question again, you see any comorbid factors there or not? Yes, you should ask. Upper motor neuron involvement is there or not? Yes, you should ask. What is the distribution of the weakness, proximal or distal? You should ask. What is the system involved? Is it motor, sensory, autonomic, or combination? That should be asked. But electromyography in a case of peripheral neuropathy is not required. So what is the question? All of the following questions are important for the history and physical examination except. So what will be the answer? The answer is C. Okay. Next. Now we will discuss one last question. Yeah. So this should be an easy question and I don't feel any difficulty in this question at all. Yes, Shadi Shuda, you should answer this. We have a 57-year-old from Vietnam. He is evaluated for primary care giver for dysesthesias that have been presented in hands and as well as feet. So what is the main complaint? Dysesthesia. Right? Dysesthesia. Okay? Right? And he also reports some difficulty in walking. His past medical history is notable for hypertriglyceridemia, tobacco abuse, and recently discovered purified protein derivative within the sputum that is smear negative for Mycobacterium tuberculosis. His medication include niacin, aspirin, isoniazid. Which of the following is likely to reverse the symptoms of these individuals? Yes, demic fusion. Sir, how we will patient know motor or sensory? Okay. Now, if there is any muscle weakness, right? if there is any muscle weakness, like for example difficulty in raising the arm, right, or difficulty in holding the pen, or difficulty in buttoning, that is your motor weakness. That is your motor weakness. And how we will know the sensory involvement? Presence of, like in this question you see, presence of paresthesias, tingling, numbness, burning sensation in the feet, that is your sensory involvement. Okay, yes, demic fusion, is that clear? Right, so what is the answer to this question? No. The answer is very good, Jyoti Khanna. So the answer is pyridoxine. The answer is pyridoxine. Okay. So what is this patient presenting to you? This patient is presenting to you with the history of dysesthesias. Dysesthesias is nothing but abnormal sensations. Abnormal sensations of peripheral neuropathy. Right, abnormal sensations of peripheral neuropathy. Okay, so now remember this important point. This dysesthesias or features of peripheral neuropathy in these individuals is mainly because of this isoniazid. Is mainly because of this isoniazid. So what this isoniazid will do? Isoniazid will cause deficiency of your pyridoxine. Right, will cause deficiency of this pyridoxine. Now you should also know why isoniazid will cause the pyridoxine deficiency. The reason is that isoniazid will inhibit an enzyme called pyridoxal phosphokinase. Now once the isoniazid inhibits this pyridoxal phosphokinase, that will result in the pyridoxine deficiency. That will result in pyridoxine deficiency, and they subsequently also develop neuropathy. They subsequently develop neuropathy. So in case of pyridoxal phosphokinase deficiency, what will happen? Pyridoxine is not formed. When pyridoxine is not formed, the individual will have B6 deficiency, and because of which the individual will have this particular dysesthesias. Right, because of which the individual will have what is called as dysesthesias. And to this particular dysesthesia, what we need to give to reverse dysesthesia? We need to give pyridoxine. Right, we need to give pyridoxine. Okay, so these are some of the clinical based questions related to your neurology in this session. So please be prepared for the difficult clinical based questions for your FMGE exam. Don't be under the impression that exam will be very easy with some single liners or and all. Be prepared with all these type of clinical based questions in your upcoming FMGE exam. So I will wind up this session, and again we will see tomorrow with some more important clinical based questions. Thank you very much.